Hello. Today we will discuss about the examination of respiratory system. Like any system examination, your examination should be purposeful. In other words, you know what are the signs you are looking for, the signs that is relevant to respiratory system. Because you need to comment whether they are present or even not present. Those who are not present, the signs but still relevant, they are known as what we call relevant negatives, and they are important. So let us start now. Examination of respiratory system actually starts like any other system when the persons start walking into your room or you start walking to the patient. You appreciate the patient, you start noticing how they talk, how they move, their gesture, and these are all information that will feed back to you as to what's the patient's condition. Never forget to introduce yourself to the patient. So Mr. Felix has kindly agreed to help us in today's demonstration. So Mr. Felix, welcome again, and thank you for allowing us to examine you. First, you start with a general inspection. Is he alert, confused, or is he drowsy? Make all this obvious comment. Does he have a drip? And then mention whether is he in distress or not. For respiratory system, respiratory distress is an important feature. By that I mean whether he is having an increased respiratory rate, whether he's tachypneic. Tachypneic is different from dyspnea. Dyspnea is a sense of breathlessness which you can elicit from the history. Whereas tachypneic is an objective measurement of the respiratory rate. So you measure that counting up to about 30 seconds, or better still, up to 1 minute. So you can put your hands on the chest and see the movement and count it accordingly. Never forget also to feel the pulse and to do other vital signs. Now, before completion of the general inspection, you should always inspect what is surrounding the patient. Don't forget that, because it gives so much clues as to what the patient is suffering from and what they are needing. For example, you might notice that there's a sputum port. A sputum port with sputum inside, and green color might indicate infection of the lung. Or there may be a peak flow meter, which indicates he's suffering from airway diseases, oxygen, how much supplement oxygen he's requiring, or with a nebulizer cap, or with humidifier. These are all important clues as to what the patient may be having. Then we proceed to examine of the hands, head, and neck before we arrive to examination of the chest proper. So Mr. Felix, I'd like to examine your hands. Can you just lift up your hands and show me? Now, a lot of students are very keen to start holding hands and things like that, but you get a lot of information first by just looking. So you look at the hands, and you ask them to lift up, look both hands at the same time. You observe if there's any finger clubbing. Finger clubbing is present when there's loss of the nail and the nail fold angle. And instead of stooping down to look at the angle, you lift up the hand to look, which looks much more professional. Look for fingernail clubbing. You look whether there's evidence of tar staining from cigarette smoking. You look whether there's any hand deformities, which can be an indication of some form of systemic disease or connective tissue disease the patient is suffering from. And these are diseases that may affect the pulmonary system. For example, there might be rheumatoid arthritis deformities due to that. Also, by lifting up the hands, you can observe whether the patient has a fine tremor. For example, in patients with asthma, they're taking nebulized short-acting beta-2 agonist, which used to give a fine tremor. To elicit that, you might want to put a piece of paper and just to observe whether it moves, and the paper would accentuate any fine tremor. Finally, you just ask the patient to cock up their hands this way, Mr. Felix, and try to elicit what we call a flapping tremor. It has to be cock up, hyperextension, really, as much as possible. It has to hold for at least 30 seconds, better still up to 1 minute, before you can confidently say that there's no flapping tremor. Flapping tremor is a very coarse tremor. It's flapping in nature. It indicates in the context of a respiratory disease the presence of CO2 retention, in other words, type 2 respiratory failure. The person retains CO2 and also have other evidence of CO2 retention, such as dilated superficial veins, warm hands, sweaty. He may be drowsy. You look at the conjunctiva, there's edema there, so-called chemosis. And you look at the fundus through a fundoscopy, you might discover papilledema. So this is the consortium of CO2 retention signs. Also, you can look at the other side of the hands, look for evidence of anemia and perhaps pulmonary erythema, which can occur in the context of pneumonia too. Now I'm going to look at examination. I'm going to look at the head. Felix, can you take off your spectacles? Thank you very much. Okay. First, I look for anemia or polycythemia, which is not uncommon in chronic respiratory diseases. Felix, if you look up, and I pull down the conjunctiva, and I notice whether is it pale or is it very red. And I can look for evidence of jaundice, which perhaps are not too relevant in the respiratory, but in some diseases like mycoplasma pneumonia can cause hemolytic anemia too. So Felix, if you look down, I'm going to lift up here and look at the sclera, observe the sclera for evidence of jaundice. Next, I'd like to look at the mouth. Stick out your tongue. I look at the tongue and the mucous membrane to look for evidence of central cyanosis. By the way, I can look for peripheral cyanosis here too. Central cyanosis will be a stronger indication of the seriousness of hypoxia. Now, it's best thing to observe under natural light, not by your torchlight or in the room light. Natural light will give the best indication of whether central cyanosis is present. Thank you. You can put it back now. And central cyanosis is an indication of the level of deoxygenated hemoglobin. Before I forget, there are some rarer signs in the face, for example, Horner syndrome. Horner syndrome constitutes a small pupil, partial ptosis, indrawing of the eye orbit, so-called aphnophthalmos, and also there's anhidrosis of the side of the face. And Horner syndrome can present in a lung condition whenever there's extensive tumor involvement and where they affected the sympathetic chain. Now we examine the neck before we arrive to the chest proper. Make sure there's adequate exposure of the neck. Felix, do you mind if I just take this off? Yeah, okay. Thank you. First of all, observe if there's any swelling. Swelling such as a goiter. Goiter can become retrosternal and obstruct the trachea, giving rise to breathlessness and an inspiratory wheeze, which is noisy, so-called stridor. Or other types of swelling, for example, in the supraclavicular fossa, in the neck, cervical change, which indicates there are lymphadenopathies, supraclavicular and cervical. Also, you will look for evidence of dilated veins. Normally, you and I should not have any dilated veins in the neck. And if they are dilated, for example, external jugular vein, which is usually found here, or internal jugular vein, that may indicate the presence of superior vena cava obstruction. Let's go to examination of the chest proper now. Now, it's very important to position the patient well as to have adequate exposure. Felix, if you don't mind, take off the shirt. Thank you very much. We position the patient for 45 degrees for examination of the respiratory system, not lying flat. And I'd like him to take off completely. They have a good look. It's always good to examine the chest, to looking for asymmetry or any changes in chest expansion from the back of the bed. So I observe here whether there's any asymmetry. And Felix, if you could take a deep breath in, I can look very well, breathe out, thank you. I can see if there's any changes of chest expansion. And if I have not measured the respiratory rate, I will do so here now again, if necessary. Then I'll observe for the shape of the chest. Now, there are different shapes that tell me different conditions. For example, there's what is known as a pigeon chest. Pigeon chest is also known as pectus carinatum, which means that it's this in shape. When you see this, it indicates that the individual suffers from some form of respiratory condition from young. They have a chronic respiratory condition, so much so that during their development age, the chests are constantly be pulled in such a way to develop this shape. There's another condition or deformity known as pectus excavatum, which is the opposite. Pectus excavatum tends to be congenital in nature, and it usually doesn't cause much problem, with the exception of displacement of the mediastinum structure. And that tells me some problems there sometimes. Next, I'll look for scars. Now, in the chest context, the important scars are usually done on the sides. For example, a scars which revolve the resection of the lung are usually known as a thoracotomy scar, and usually done on the side, which involve resection of the rib. There are other scars such as pleural aspiration or pleural biopsy, and there are small scars that can easily miss if you do not look for it. Another important observation of the shape is also to do with hyperinflation, the signs of a hyperinflated chest. Because normally when you look at this chest, you and I, our anterior-posterior diameter should not exceed 70% of the transverse diameter of the chest. Now, if it exceeds there, if it approximates 1 to become 1, it gives the appearance of a barrel chest. And these are a sign of a hyperinflated chest. Other signs are that you will see the intercostal here spaces actually recesses during inspiration. Normally, you don't see that. When that happens, it indicates also another sign of hyperinflation. The reason for this is that when the chest is hyperinflated, the diaphragm, instead of a dome shape, is flattened, and therefore they contract horizontally, giving rise to those appearances. After inspection, I now palpate. I palpate now for chest expansion. I'm going to palpate chest expansion on the upper zones, the middle zones, and the lower zones. Now for expansion, I really need them to take an aspiration fully. Then during expiration, I approximate my 2 fingers. Then after that, they'll take a deep inspiration and I'll see how much the chest movement is able to take place. So if you take a deep breath in, breathe out, breathe in, out. Take a deep breath in, breathe out, breathe in, breathe out. Take a deep breath in, breathe out, and grab the muscle over here, deep breath in, breathe out. Normally, at the mid to lower zone, the separation of the finger should be at least 5 centimeters for a normal chest. Next, I'll palpate for the trachea and the apex. The trachea and apex should be always taught together in a respiratory context. Why? Because their movement or their position indicates to me any mediastinum shift or any volume lost or volume expansion. For example, if there's lung fibrosis on this end, the trachea might be pulled towards that side. If there's a gross pneumothorax on this side, the trachea might be pushed towards the other side. Similarly, apex might be displaced. Or if there's a huge pleural effusion, the trachea might be pushed towards the other side and the apex beat becomes impalpable. Therefore, both should always be done together. For palpation of the trachea, this is what we'll do. First, I need to feel the trachea. And it's always felt a bit intrusive, so I always warn the patient, Felix, I'm going to feel your trachea. It might be a bit uncomfortable. So I have to feel the trachea and also the two sides of the trachea. And if possible, I should go as deeply down as possible to appreciate the direction of the trachea, whether it's deviated towards left or right. Okay? The other way is doing 2 fingers over the 2 junctions here and just appreciate the 2 sides. If you cannot feel the groove on one side, that would indicate the trachea is being moved towards that side. The other one is the apex beat. Now for respiratory system, I only need to appreciate the position of apex beat. Whereas if you're doing a cardiac examination, you also need to comment about the nature of the apex beat, whether is it heaving or whether is it thrusting. To complete the examination of the trachea, I want to mention 2 things. Number 1 is what is known as tracheal descent on inspiration. If you and I put our finger, our own trachea, and if you take a deep breath in, the trachea is actually stationary. It's the chest that actually moves. But in the patient who has hyperinflated chest, you feel the trachea actually being pulled down into the chest wall, and therefore is known as tracheal descent on inspiration. This is different from what is known as tracheal tach. Tracheal tach is usually occur in the context of thoracic aneurysm, where the pulsation of the aneurysm pulls on the trachea, giving rise to the sensation of a tach. Now, the second thing about trachea is the sign of the distance between the cricoid cartilage and the sternal notch. If I lift up Felix here, this is the thyroid cartilage, and this is the cricoid cartilage. The distance between the sternal notch and the crico is called cricosternal distance. Normally, you and I can admit 3 fingers. But if someone with hyperinflated chest, it will be less than 3 fingers. Rather subjective, but it's actually a very easily appreciable sign. Before finishing the palpation, never forget to perform tactile parameters. Again, remember the 3 zones: upper zones, mid zones, and lower zones. Now, Mr. Phillips, can you say for me 99?
99.
Again?
99.
Again?
99.
Again?
99.
Again?
99.
Again?
99.
And also tactile parameters on the axilla. Now, the way to expose the axilla is either you can do it this way, Or better still, if you could ask the patient to lift up their arms this way and put it behind your head. Felix, can you do that? Thank you very much. Say 99.
99.
99.
99.
Again.
99.
Again.
99.
What you're trying to do is that by tactile, by feeling it, you feel the vibration of the voice hitting your hand. It has to be firm and it has to be within the intercostal space. If you feel that this is not a good way, other methods, just simply using the palms of your hand, you can just feel it. 99, 99, 99, 99, 99, 99, etc., etc. Percussion, the whole thing lies in your percussion technique. If your percussion technique is good, you're able to accurately interpret the signs. You should percuss with your middle finger onto the other middle finger, and it's on the middle phalanx. Percussion note should be like playing the staccato in your piano. Ta, ta. Using your wrist movement, not using the whole hand. In other words, percussion of the upper zones. Then the axilla. And not to forget the apex of the lung. This way, in percussion of the apex, we percuss over the clavicle. So clavicle now behaves like my middle finger here. Resonant. Now, sometimes it's also a good practice to percuss over the supraclavicular fossa. For this purpose, it's easier to sit the patient up. And we'll do it slowly here. Okay. We'll turn over the other side. Over here. And I'll put my finger here, 3 fingers. There are different ways of doing. The way I'll do it is 3 fingers here. First finger on the clavicle. The third finger over the trapezius muscle, and the third one is in the fossa. So it should be down because of bone, resonant because of apex, and down because of muscle mass. Same thing, I do it on the other side. Over here, down, resonant, down. You would notice just now the percussion note over this lower area and this lower area is down. Why? Because that's normal. You have your cardiac downers here, and you also have your lever downers here. The lever downers usually reaches up to 4th intercostal space on the right side. Another sign of hyperinflated chest will be the loss of cardiac downers and loss of hepatic downers. In other words, they sound resonant as you percuss downwards. Why? Because of reflection of the lung, covering over the lung, over the heart as well as the liver. Now, let's have a quick recap. For the percussion of the lung, routinely we start by percussing the apices of the lung, then the upper zones, mid zones, and lower zones of both sides of the lung. Then finally, never forget to percuss the axilla. We now proceed to auscultation. In auscultation, we're listening for 3 things. We're listening for, number 1, the intensity of the breath sound. And some people call it air entry. When there's consolidation of fibrosis, the intensity of breath sound is reduced. Next, you're listening for the nature of the breath sound, whether this is bronchial in nature, vesicular in nature, or broncho-vesicular. Bronchial breathing occurs when you auscultate over the major airway. They are bronchial in nature. Whereas in the lung parenchyma, peripheral, it is vesicular in nature. So for most purpose, when you auscultate, you should be hearing vesicular breath sound. what is bronchial sound and what is vesicular breath sound? If you look at books, it talks about inspiratory and expiratory phase. In vesicular breath sound, which you normally hear, will be a long inspiratory phase followed by a short expiratory phase. Will be something like this. Long plus a short, and it's a softer expiratory phase. Whereas bronchial sound will be a long inspiratory phase as well as a long expiratory and louder expiratory phase, plus a gap in between the two phases. It will be something like this. With a gap in between inspiratory and expiratory. There are possibility of broncho-vesicular breath sound too. Now the third aspect of a breath sound is what we know as the added sounds. Now added sounds can be wheezes or rhonchi, crepitations, or pleural rub. What are wheezes or rhonchi? They are musical sound that occur because of air passing through a narrowed passage. And they can be either essentially an inspiratory wheeze or expiratory wheeze. For lung parenchyma in diffuse lung disease, airway disease, such as asthma or COPD, you would normally hear expiratory wheezes. Whereas, if it's a major airway, you hear an inspiratory wheeze. An inspiratory wheeze that becomes so loud that you can hear it from the bedside, that is when you start to use the term stridor. Crepitations. Crepitations are sounds that can be fine crepitations or coarse crepitations, depending on the nature of secretions that is inside the lung or the airway. For example, if it's consolidated lung, you might hear a lot of coarse crepitations. Or if it's bronchiectasis, there's a lot of secretions in abnormally dilated bronchi, you hear a lot of coarse secretions sound, manifesting as coarse inspiratory crepitations. Or fine crepitations such as pulmonary edema, fluids collect in the interstitium of the lung because of left ventricular failure. For example, you hear fine crepitations, which is inspiratory in nature. How about pleural rub? Pleural rub occur when there's pleurisy. When there's pleural is involved, is inflamed, and they rub against each other. It's a scratchy, superficial sound. If you rub your finger between your hairs here, you hear the sound, and that is a superficial, scratchy sound, and you can easily miss sometimes in the presence of coarse crepitations. When you hear that, that indicates pleural involvement or pleurisy. So let's do that now. Take a deep breath in, out, in, out, in, out, in, out, in, out, in, out. Can you put your arms this way? The breath in, out, in, out, in, out, in, out. Okay, you can put your arms down. And it's also a good habit to auscultate for the apex of the lung over the supraclavicular fossa. This I tend to use the bell because of the limitation of space there. Take a deep breath in, out, in, out. And before to complete auscultation, I will check for vocal fremetus. I'll ask him to say 99 and to hear the sound, whether there's any differences. Okay, Mr. Phillips, can you try? Say 99.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
And similarly in the axilla and similarly in the apex. In Malaysia, our culture, if you like, you can use the word nenek, which sounds like 99. The syllabus sounds similarly, so you can do nenek, 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 nenek. That's the end of auscultation, and that's the end of examining the respiratory system from the front. But it's not finished yet, because you have to examine the back. Very similarly, we start with inspection. Inspection for evidence of scars, inspection for any asymmetry of movement. Take a deep breath in, out, and then specifically on the back, remember to look at the spine, the alignment of spine. Because very often you might see cases of kyphosis, which is the forward bending of the spine, or scoliosis, which is the lateral bending of the spine. Kyphoscoliosis can severely affect the respiratory reserve. So it's important to elicit this sign because you might want to have surgically correct the spinal deformities. Next, we'll palpate. Palpate for chest expansion in the same fashion. Take a deep breath in, out, 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 deep breath in, out. You can appreciate the expansion this way. Then you do your tactile parameters. Say 99, again, 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 again. Now, as opposed to the front where you have to palpate for your trachea and apex vid, behind we palpate for the cervical and supraclavicular lymph nodes over here. So it's important to bear in mind that you would feel for the supraclavicular lymph nodes behind, from the back. You also want to palpate for the cervical chain, the lower, middle, upper, and the posterior triangle of the neck, and the anterior triangle of the neck. And if you like, carry on palpating the lymph node that is situated in the base of the skull. Next, we go for percussion. Now for percussion, it's important to get the scapula here out of the way. You can percuss over the scapula too, but it might be a better idea to get it away. And the way we do it is either asking the patient to cross their arms in their front. And if you could do it, just press front, okay, cross it, and see how it actually can swing away the medial border of the scapula away. The other way to do it is actually just to let the patient lean forward 2 or 3 pillows. You can put your arms over it, grabbing it, something then over here. And that would also exposes the lung better. Now I'm going to percuss now, similarly. Percussion. Auscultation. In the same fashion, now listen. Take a deep breath in, out, in, out, in, out, in, out, in, out, in, out. Say 99.
99,
Say 99.
99,
Say nene, 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 nene. That completes the examination of the respiratory system at the front as well as at the back. But there's one thing I'd like to mention. We examine and we talk in terms of zones, upper zones, middle zone, lower zones. But bear in mind that in the real lung situation, at the back, you are assessing mainly the lower lobes. Why? Because your oblique fissure runs between the 4th thoracic spine all the way down here towards the xiphisternal junction. Because of the oblique fissure in this fashion, the part here is upper lobes, and here is mainly the lower lobes plus the middle lobe. The middle lobes are situated mainly in the front, and the upper lobes are also situated mainly in the front. So when you examine the back, you are listening primarily at the lower lobes. When listening from the front, you examine primarily the upper lobes and the middle lobes. So let's have a quick recap, the whole thing. Examination of the respiratory system. Number one, be purposeful. You need to know what physical signs you're looking at, the signs that is relevant in the respiratory system. Central cyanosis, finger clubbing, these are things that are particularly important in a respiratory context. Then when you examine, you start with general inspection of the patient, including the surrounding, which give you many clues as to what the patient is having. Next, you need to examine the hands, the head, and the neck. And after that, you come to the chest proper. You do it and examine at the end of the break, good observation. Then you come and examine the rest from starting by inspection, palpation, percussion, auscultation. Then you go to the back, same thing. Never forget your axilla. Thank you.